had this flow, and now the surgeon can say, actually, there's a vessel there now that I could create into a fistula. So now they'll take the artery and hook it into that vein. So, God, I did learn a lot about dialysis, sorry. So, one of the problems is what you're going to see. This is why you have these really sick patients, because they all have cardiovascular disease. I've never seen a dialysis patient yet, even a child, that does not have some form of cardiovascular disease. Hypertension and anemia, pericarditis. So uremia is an irritant. That's why they usually grouchy dialysis patients too, because it irritates the brain and it irritates the pericardium. Because they're also going into fluid overloads all the time. They usually have pericarditis. If a patient is in severe fluid overload, you will hear a pericardial rub. So, and remember the difference, how you tell a pericardial rub between a pleural rub? Pleural rub's only heard on inspiration. Pericardial rub is there constantly because it's the heart beating. Okay. So do sometimes see that, but they all have enlarged hearts. They have enlarged left ventricles. They've all got hypertrophy of that left ventricular wall. They all at some point will have a CHF episode, so that's the problems you run in the unit. Pulmonary edema. They all get, because they have an infection process going on, an inflammatory process, I should say, because they are getting exposed to just running the blood through the dialysis machine. They're going to have a reaction each time, a mild reaction. They all have mild inflammatory responses. They've got reduced immune systems. As soon as you start having things like urea and creatinine and all these toxins, your immune system goes to pot. They basically got renal osteodystrophy. They all get bone. They used to get really bad bone pain in the old days. Not so much now, but they used to complain of bone pain. They've got arthritis. They're going to have fractures. Hyperparathyroidism, calcification of the vessels because of the calcium imbalance that we've got going on with the parathyroid hormone. So you often find that their veins can be crunchy if you are putting an IV into them, if they've been on dialysis a while. Metabolic acidosis, because again, the kidney is not helping to buffer that system with the bicarb and deal with those hydrogen ions. Iron deficiency anemias. And the reason being is there's this rapid turnover of red blood cells in a dialysis patient, because every time they dialyze, they're losing some of those red blood cells. Even though we try and rinse as many back, they're getting that. The other problem with dialysis is you force those red blood cells through a pump and then that filter, you actually cause damage to the red blood cells. So they get anemias because of that, because they're not nice, healthy, plump little red blood cells. When I first started dialysis, I had calluses. We were told that we used to have to chase the blood back to the patient with the blue clamp, because we were trying to get their blood back and we were agitating. They then figured out we were actually causing damage, because every time we squeezed down, we were damaging those red blood cells. But I did have calluses for a long time. Glad they got rid of that. Again, sexual dysfunction, ozotemia, high levels of nitrogen-containing compounds in their body, again, because they're not making the urine, and uremia, which I just talked about, the pericarditis and several of them. So when you go to dialysis unit, okay, just a little thing about dialysis units is they are an outpatient clinic. Those nurses are very focused on the world of dialysis. And you sometimes think, well, like I remember you telling me about that patient that had atrial fib and they'd been previously hospitalized, and you said, why did they give 3 nitro? And I get mad too, because I'm thinking, yeah, why didn't they feel a pulse? They don't have 12 leads per EKG. They haven't even got a heart monitor. So they don't know what heart rhythm they're in. But if you feel someone's pulse and it's rapid, thready, and irregular, you can pretty much think, they're probably in atrial fib, especially if the patient's saying I was just admitted for it. And yeah, why would you give 3 nitro to that patient? Because you're just going to dump their pressure. So sometimes some of the things that the staff do there, you will kind of wonder, why did they do that? It's because they're not used to working in the world outside of dialysis. They have an AED, that is what they have. So you're asking about what happens to patients in the middle of dialysis. So they come in with 4 kilos or 3 kilos to lose. We hope it's going to be more like 3 kilos. We do give them a fluid restriction. They're usually heavier on a Monday because they've got an extra day. If you think about the classic patients, either Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. Okay. Monday is the worst time for a dialysis patient usually because they're more fluid overloaded and they're more likely to have high potassium. And they're probably exhausted if they've had like a busy weekend, it's the family or whatever. So you're trying to remove that fluid. The dialyzer is really efficient at removing fluid. It will remove it way quicker than what that fluid can move from the intracellular, extracellular spaces into the blood. So what happens is when you become fluid overloaded, there's only so much stays in the circulation system. Where do we put it? We put it out as edema, right? And it tends to be down there in the feet. So we're pulling that fluid off quick and we're creating a space, and what we call the osmotic differential. So, you know, it's low volume here to try and encourage that fluid to then move across into the intravascular space. Well, what usually happens is halfway through, the body is not catching up. We've removed a volume, and even though we've taken blood pressures every, say, 15 minutes on someone that we know has a problem, we might catch in time. They usually get their blood pressures taken every 30 minutes. And it might be that little window where that patient was okay, and the next minute they've gone, they're out. We've removed too much volume. The same can be said, though, is also about the electrolytes that we're removing. So if we're removing potassium or some of these electrolytes, there's sometimes some of the patients, they might actually have a lower potassium, and it might start causing cardiac irritability, PVCs. They might actually say to us, oh, I don't feel good, I've got like chest pressure, or something's not right.
So that's like
usually why
they call up for chest pain, or they say, well, they were kind of altered when they got in, now we're halfway through, they're still altered.
Because we really hope that basically by removing that fluid, we're going to then allow the heart to beat. I don't know whether anyone's heard of the, you'll have heard of it, but Starling's curve, you know. So his hypothesis is that, you know, so if you think I've just said that these patients have big boggy hearts, so they're used to having a large volume to push to create blood pressure, we've now emptied that sac. So sometimes we'll give them fluid boluses, we'll elevate their feet, but sometimes it's just not enough. That it's gone past that point and they've got chest pain now.
And electrolytes.
Yeah, and electrolytes. Yeah. And then you also, these patients, some of them we figure it out, they just always need to have oxygen when they're on the dialysis machine. We used to have this really lovely little box of tricks that we used to basically measure the changes on hematocrit. Fortunately, DaVita came and took it away from us. You could manage the patients much better because as you dehydrate a patient, the hematocrit goes up. We knew that there was a threshold through studies that the threshold was when you have a 15% change on hematocrit going up, you're reaching the threshold for that patient and you should back off fluid removal. So we would actually alter and tailor the fluid removal based on hematocrit changes. We'd sometimes put a patient on a machine and we'd see a sudden drop. Well, that used to basically tell us that there's probably circulation going on, and we're not really looking at the whole patient's circulation. We just have circulation going on, and we just dehydrate in that little area. So unfortunately, we don't have it anymore, but there is programs on the machine which alter the way the fluid's removed. It's not just taken off at one level. But yeah, it'll happen. It'll just, you know, depending on that patient's situation. I mean, it might be that we also sometimes throw thrombus. It might be because like the heart's now starting to beat faster and they've got those plaques in there, and now we've thrown a plaque. Okay.
Why don't they just, if you're saying that they're not catching up, why don't they just slow down and let them catch up?
We don't know because again, patients are on beta blockers. These are dialysis patients who have a deranged blood pressure system anyway because the kidneys' renin-angiotensin system is all. Most of them are on blood pressure meds. We have to actually figure out which patients can take BP meds before coming to dialysis, because most of them we tell them don't, because we don't want them to bottom out while we're trying to remove the fluid. It is very complicated. It is. It could be to do with they had a salty meal. They hold on to that fluid differently than they normally do. Infection. Infection's usually a catheter patient. If they've got an infection, you've got sepsis going on, and we don't necessarily know about it because a dialysis patient has a compromised immune system. They don't necessarily have a fever like you and I would. In fact, a dialysis patient is sometimes hypothermic, so you can usually add an extra degree. So a dialysis patient has got a temperature of 98. That's more like 99 for them. So there's multiple things going on, but usually what we're looking at is volume shifts. It's caused something. If it's halfway through,
So
or it's an
what do they do for them
oxygenation
at
issue.
the ER when they call us and they say, like, they came in altered, they're still altered, we're halfway through, they're a little hypotensive now, like, what happens at the ER then that, like,
Other than a transfer back to.
yeah, because most of the time, I
They
feel
go
like
to,
we
basically, it's a waiting game.
Okay.
I mean, if they're really severe, they'll put them on inotropes.
LDUC.
You know, they'll put them on vasoactive meds if it's really severe. But basically, they'll give them some volume, they'll give them some oxygen. They will maybe look at the blood pressure, you know, at that.
Because I
But
feel
that-
like I am very hesitant. Like the last person I had, like I called and I was like, so they're a little hypotensive. Like, how much of any do you want me to give them? Because I don't want to screw them up worse
Right.
by just dumping a bunch of saline.
Well, here's the thing. Do your assessment, listen to the lungs. Find out, have they got crackles? Have they got sage-ect? Some of them will be able to present with a regular JVD. Catheter patients are hard, but also look at that. I mean, is the bounding pulses going on up here? But the lungs is what you really want to listen to. Because, and the heart sounds, like if say they've got ribs going on, because that's really going to let you know, yeah, this patient's fluid overloaded, okay? So those are the ones you're just going to give them oxygen. You might want to, it depends on the blood pressure. If they're having chest pain, obviously, I'd be hesitant more with nitro on a dialysis patient. You want to get that 12 lead EKG. That's really what you want to be getting. Yeah, exactly. That's what I was going to go with. If you've got rails, crackles, wet lungs, you want to get the CPAP on them.
And then you're saying they're usually hypotensive, so that's something that you
Right.
need to call and.
And they're altered, so those.
And it might be that,
Yeah.
and it
Right.
could be, you just give them 250
And they're altered, yeah.
Yeah.
I mean, well, that
You
would
don't,
like,
you
like
don't go
making
crazy
sure, yeah.
increasing fluid into these patients.
I've
You would
seen
probably
it.
say no more than a 500 ml bolus, because by
Yeah.
the time you get to the ER, that is probably all you're getting in anyway, but no more than 500 mils.
Yeah, well,
Let
and then
them
Templeton
decide
are like,
that. Yeah. Because we might have already
Right
given
there.
them some of the fluids anyway, because usually what happens is once we start seeing those symptoms, we'll start giving them fluids. Okay. We used to give albumin. They used to let us use 25% albumin. The problem with albumin is albumin's about 70% more viscous than blood. So if you've already got a failing heart that's really tired, and you throw in something that's like really thick and sticky, and I'm like, oh, I really can't get blood pressure now. And I've seen it go into MI, full on MIs of cardiac arrest. So albumin they moved away from, because this is the other part of it, is what helps attract fluid into the blood is proteins. Most of dialysis patients, especially if they've got liver failure as well, have a low albumin. So that's part of it as well. But you know, elevate the legs, get some of that blood flow going back down there. But that's pretty much, they are difficult to manage, and that's why the medication history is really important. But the reason I ask that the patients a DNR straight away, we do have DNR patients. Sometimes people go running straight into a cold, don't think to ask.
oh,
them.
I feel like this group of people, like that's kind of a good.
But no, but you're assuming that dialysis
Am I wrong?
will not be
Very
a patient if they're
first
DNR, right?
don't do anything.
The problem with the dialysis units here is they have movable staff and they're so like sometimes running around with a, you know, like
There is
chicken
kind of
with
a-
a head cut off.
There's a
because it is-
level of anxiety sometimes when you
Yeah.
walk in there.
There is, and I'm going to warn you that because, and sometimes they would have totally forgot to think, oh, this patient's a DNR. Because you're going to maybe think, if they're already working this patient, oh, they're full code, right? Just
Well, they
sometimes
have
ask that.
relationships with these patients too, you know, they're there
Yeah.
all, you know.
You
several
assume
times a
that,
week.
but in this county right now, some of the nurses are traveling around and we have travel staff because it's really hard to keep.
Well, and when they're altered, I'm like, well, what's their number?
Like,
Normally they're more chatty.
Exploding blood bag.
That doesn't really tell me
Well,
a
it's
whole lot.
just,
Maybe
it's
they
really
don't like
hard
to
work and underpaid and very stressful.
Sounds like a wonderful
It's a tough
thing to
job. Oh yeah, it can be fun and games at the dialysis unit. So anyway, information that they can give you though is, we draw some of these patients actually do get weekly potassiums because they are potassium abusers. They basically don't want to regulate their diet because all good food has potassium in it. So basically when you look at a potassium poor diet, basically keep away from bananas, chocolate, coffee, mushrooms, strawberries, any red fruit, peppers, tomatoes. So yeah,
Green vegetables.
yeah, dried fruit, anything that is being dehydrated, potassium goes up. So you can kind of understand, so you know, they go to like a family gathering on Thanksgiving, oh, if I just have a little bit of this and a little bit of that, well, the next thing they know, the potassium's gone up. So yeah, Yeah, and like ask them, like, well, ask the staff, do they run a high potassium? Because they might say, oh yeah, they're on like a 0K bath, which means if they're on a 0K or a 1K bath, that means they're running high potassiums. So yeah, so they can give you the labs. We draw them monthly or bi-monthly, and someone can be printing those out for you. They can be printing out the H&P along with the face sheet. And they can also, it might be that they've just been in hospital. They might have some chest x-ray, whatever they can give you. 12 lead, definitely. You need to do a 12 lead because that will also help to see if there's maybe tamponade.
Yeah, but if they've got pericarditis, hypertrophy, you name like 3 mimickers and it's gonna come up as like star.
Yeah. So yeah, they've got that going on. Ask what do you think they're anemic? Because it'd be the hemoglobin. If you've got like no red blood cells, so you've got no oxygen being carried out, what does the heart do? It has to compensate by beating faster. And if you've got this large buggy heart that's fluid overload, and oh my God, I've got to get the oxygen out to the brain and the rest of the body, it's going to get exhausted. So ask them, it might be that this patient purely needs a blood transfusion.
I feel like a lot of them are not real receptive to our questions at all. They're very defensive.
Really?
Oh yeah.
Yeah, it's like I've done this so long.
I don't think that's necessarily specific.
Because I can
to
tell
them.
It's just you. It's all the context of that, yes.
The problem with them is they're so
It's not the
like
question, it's how
stressed.
it's.
I think if you can direct,
I'm
if
not
like
saying everyone does, but
Right.
I ask nicely and then some, like, I don't know, sometimes.
I'm
Oh,
very
seriously,
nice
it's the
on the
one
phone, and
person.
most places that we call it, they don't understand why we need to ask all these questions.
Right.
It's like, all we do is we come, we scoop them up, and we leave.
Yeah.
Yeah.
you could say this to them, say like, for me to be able to let the doctor know what may be going wrong with this patient, I need this information. Can one person get this from the chart? And if they then realize, oh, I got this job,
which is great.
someone can do it. But maybe if they, if you just plain and simple say, hey, we need this information so we can treat the patient correctly.
Right.
And ask them, say, what do you think? They can tell you, oh yeah, I think they're fluid overload. Yeah, I think the potassium is this, or this has been going on with them. We have patients that are getting chemo. Chemo patients, what does it do? It causes them to go into heart failure. Chemo's awful for the heart. Some of them have heart problems as well. But usually you want to get the oxygen on them. You want to get them with their feet up at the, to help with fluid to drain back down there into the circulation. That's what you want to do with them. Be prepared for them to vomit as well. We get that on the machine a lot. They dump their pressures and they start vomiting. So if that's happened, maybe it's aspiration pneumonia could now be a problem because we do have them vomiting. Ask about the heparin as well. Maybe it's just say like, did they get a lot of heparin? If that's going to be a concern. Are they getting antibiotics for an infection? So if someone tanks out on the machine because they're septic, because they're vasodilating everything out and their blood pressure drops, that's really important for them to know at the hospital, in the ER. Do they still need to give more antibiotics? Do they need to start drawing more blood cultures? Do we need to do a lactate level? Is this patient going into full-on sepsis? A dialysis patient will very quickly go into sepsis and need to be on the ICU. You can see visible signs of infection like the dialysis catheter right there. Actually, ask about the baseline conditions like neuro. How are they normally? Because some of our patients aren't always with it. They've got dementias, they come from these old folks' homes and the nursing facilities, and some of them are kind of, not making much sense.
Well, that's why a lot of them are like, well, normally they're more chatty.
Yeah,
And I'm like, well, that doesn't necessarily give me a great idea of what their baseline is, other than that, like, maybe they're just not as peppy
They don't know
today.
you, so they're not gonna talk to you.
Yeah.
They just want to get rid of it, I'll be honest. They just like, don't code in the unit, just go, go, go. That's what they're thinking. It really is. Blood sugars. Sometimes they don't even think about it themselves. We do have diabetic patients. Get a blood sugar on one of these patients because it could purely be. Some of the patients have IV pump insulin. We don't tend to like that. Most of the patients are doing their own checks on the blood sugars. We don't routinely check blood sugars on these patients. Yeah, exactly. So check the blood sugar. It might just be that. And we do the med lists every month, so you can get a recent, usually a fairly recent copy of the meds as well. Come on, why? So catheters. So here we are. We've got a really sick patient, being on the machine, they're crashing. You want to be able to use that catheter. The dialysis nurse should be able, if it's still accessed with the dialysis machine, you prime the saline bag and get the air out of it, so spike it, get the spike out, get the air out, put the spike back in, get it on a pressure bag,